Good evening. This is a pre-Christmas recording of a subject which is close at heart to all of you. All of us are some sort of experts in managing hypertension. Hypertension is a very common event and a common presentation. And each one of us tends to individualize the treatment based on the person's individual circumstances. And most often, we are quite right in doing so. However, I'd like to just review the subject on the whole to see what everyone else is doing. And clearly, there is no exact singular method with which you could control hypertension. And I'm talking about the essential hypertension, the one which has no detectable organic cause. And as I said earlier, most of us do a pretty good job in dealing with hypertension and with related comorbidities. But here goes, I'll put in a PowerPoint slide presentation to explain what is on the offer. So as you can see, I have immediately gone microscopic, but that's of no real consequence. And so the hypertension, which has been a long-term interest of mine and also of yours as well, we begin now. The first thing to notice about hypertension is, how does one describe it? And so the general consensus is that hypertension is a level of blood pressure which is associated with significant increase of cardiovascular disease compared to the population, and one that is likely to benefit from treatment. And this is derived from explanations of definitions given for a long time by International Society of Hypertension, the Joint National Committee number 7 of WHO, Joint British Society, British Hypertension Society, and National Institute of Care Excellence. So having said that, how often do we encounter it? And I'm talking more in favor of what I have seen and have observed in the paperwork in relation to UK, and therefore it is an NHS-based observation. The systolic blood pressure and diastolic blood pressure rises with age, and that goes without saying. This is a linear relationship. So as the age advances, these two factors also increase. But there is an unusual trend. So systolic hypertension increases in a linear fashion with age. The higher the age, the more the systolic blood pressure, and the facts that we would discuss would be with atherosclerosis, rigidity, poor cardiac reserve, and diversion of blood from core elements to others. The diastolic blood pressure, on the other hand, rises with age up to 50 years of age, and then it forms a plateau for about another 10 years or so. So from 60 years onwards, the diastolic blood pressure begins to fall. So it's a relative fall. It has still increased, but is now beginning to dip down. And so if the systolic blood pressure goes up and the diastolic blood pressure trend comes down, the difference between the two levels begins to be increased. In other words, the pulse pressure, which is the difference between the systolic blood pressure and the diastolic blood pressure, increases. So this explains the unusual position of incidence of hypertension as one becomes elderly. The Health Survey of England established that the incidence of essential hypertension is 3.3% in patients who are less than 40 years of age. And the incidence is around 28% for patients who are between 40 and 80. And the incidence is almost 50% when you are evaluating patients over the age of 80. So that means almost 50% of 80 plus people have hypertension, as is defined in terms of level by NICE and other organizations. Having said that, it is also a clear observation that 50% of patients are not diagnosed at a younger age with hypertension because their blood pressure is not measured. And of the people who have been found to have hypertension, 50% do not have appropriate and sufficient treatment. So this is in respect of rule of halves. So when does a person have hypertension? So the basic baseline is an optimal blood pressure in an adult would be less than 120 systolic and less than 80 diastolic. And one would regard it as normal if the systolic blood pressure is 130 and diastolic is less than 85. The high normal blood pressure would be between 130 to 139, and the diastolic blood pressure correspondingly to be between 85 to 89 mercury. So having set the baseline, a mild version of hypertension is grade 1, when the systolic blood pressure ranges between 140 to 159, and the diastolic ranges from 90 to 99. The next step is grade 2 or moderate hypertension, when the systolic blood pressure ranges between 160 to 179, and the diastolic is between 100 to 109. Severe blood pressure is at grade 3, when the systolic blood pressure is more than 180 millimeter mercury, and the diastolic is in excess of 110 millimeter mercury. Some people will only have isolated systolic hypertension, but not diastolic hypertension. And of course, there are some borderline cases which range in this subgroup as systolic 140 to 149, which is clearly hypertensive and at grade 1, but the diastolic is less than 90. So there are unusual presentations as well. Now, what are the absolute risks of untreated hypertension? So in respect of coronary heart disease, hypertension is the most significant modifiable risk factor. By its mere presence, it increases the risk of death in stroke by 7 times. And by its mere presence, 25% deaths occur in people who have got coronary heart disease. Hypertension and coronary heart disease have a linear relationship. So the higher the hypertension, the more the risks of coronary heart disease. And of course, this led to discovery of pulse pressure, which is the difference of systolic and diastolic. And as we have already mentioned, that the systolic blood pressure keeps on getting higher with increasing age, but the diastolic blood pressure after the age of 60 falls. And so there was also an emergence of white coat hypertension. The impact of white coat hypertension is such that studies suggest that in patients who have regular white coat hypertension, have high level of insulin resistance, and that after 5 years of white coat hypertension, patients end up with essential hypertension. And in them, even with white coat hypertension, which has not yet become essential hypertension, the stroke rate is high, more than 50% if they did not have a white coat hypertension. And in elderly, 50% would develop congestive cardiac failure. In practical terms, diastolic blood pressure is the best predictor of coronary heart disease in younger patients. And systolic blood pressure and pulse pressure are the best predictors of coronary heart disease in 60 plus. And these were established on Framingham studies. So speaking about it in another way, what are the consequences of untreated hypertension? Well, in some lucky people, although rarely, hypertension at a treatable level remains asymptomatic, but it should never be considered to be a benign condition, as such patients will develop end organ damage, which brings to attention their incipient, latent, or hidden hypertension. Untreated hypertension leads to peripheral resistance. If you can imagine, the increased force of blood passing through the tube, which is elastic, will stretch it. So and of course, the muscular wall, tunica media of these large blood vessels will contract to oppose that. So that leads to increase in the peripheral resistance, which in turn leads to increased reflex rise of heart rate, and increased peripheral resistance and increased heart rate will lead on to producing increased cardiac output. And on a sustained basis, it will lead to left ventricular hypertrophy. And when this has happened, there is reduced perfusion in the coronary arteries, which produce ischemic heart disease. And if it is unchecked and carries on, it will lead to left ventricular failure or left ventricular systolic dysfunction, previously called congestive cardiac failure. Untreated hypertension would lead to cardiac issues such as angina pectoris and myocardial infarction. It can lead to cerebrovascular events such as transient ischemic attacks, transient global amnesia, stroke, vascular dementia, and encephalopathy. The other complications and problems which show up with untreated hypertension are renal failure. And so we move on from chronic renal disease to acute renal failure, retinopathy, increase of the diameter of aortic abdominal aneurysm, peripheral vascular disease. A myth has always been that patients who have got a high blood pressure will have headache. This is not true. However, when the blood pressure systolic exceeds 200, some patients do have headaches. So how does one assess a patient with hypertension? The base is set at obtaining a proper history, undertaking a clinical examination, and undertaking basic tests, which one would do, and I'm sure that you always do that anyway. So consideration is made of age, Higher age means higher hypertension. Sex, male gender provokes greater complications. Socio-economic condition means living in difficulties or deprivation. That means junk food, smoking, pollution, and environmental hazards. Also, cigarette smoking, even if it is the electronic version, will lead to further worsening of hypertension. Alcohol intake, which is in excess of acceptable or moderation. So the limit is set generally for an adult would be around 14 units per week. Also, family history is collected of cardiovascular disease, past history of diabetes, lipid abnormalities, or kidney disease. So all of these are in relation to collecting data and analyzing it. And then in terms of physical examination, you would do fundoscopy. And if you know the measures, arteriovenous nipping, and then microaneurysms and hemorrhages, then you can categorize the degree of hypertension from fundoscopic examinations. Presence or absence of edema, which represent cardiac failure. Jugular venous pressure, observation of a supine patient in respect of the jugular vein. Heart rate, blood pressure, heart sounds to elicit if there are any murmurs or carotid bruit, and pulses if these are irregular, slow, or fast. These are clinical examination observations, and they don't require any exclusive tools. Another handy method is dipstick test of the urine to exclude diabetes, hematuria, and protein. ECG 12 channel, and then basic blood tests such as urea and electrolytes, including the estimated glomerular filtration rate, HbA1c for diabetes, and lipid study. Having done that in your clinic, even before the results have arrived, you would need to do a cardiovascular risk assessment. On NHS templates, when previous blood tests have already been done for other reasons, record of these parameters remain, and they work out the mathematics of the Q risk, which is a 10-year risk for cardiovascular disease in patients between the ages of 25 to 84. So that is how you assess clinically hypertension. Of course, in young patients, you would want to rule out secondary hypertension. So therefore, you'd be looking to measure catecholamines, steroids, and other tumors which can produce raised blood pressure, renal disease, and so on. So how much reduction is needed when someone has hypertension diagnosed? Hypertension Optimal Trial, British Hypertension Society produced figures that an optimum target should be 139 over 83. But at the same time established that the lowest level of cardiovascular disease events occurred when the diastolic blood pressure falls to 82.6 or less. The lowest cardiovascular mortality with diastolic blood pressure would be in diabetics 80 diastolic blood pressure or 86.5 when there is no diabetes. In this regard, one would need to remember that aspirin reduces by 15% cardiovascular disease events and 36% stroke mortality. So what is the guidance of what agents to use when hypertension has been diagnosed, as suggested by British Hypertension Society and National Institute of Care and Health Excellence? So we have already highlighted that there are mild, moderate, and severe hypertension, and we have set up grades as well. So at step 1, the treatment suggested is angiotensin converting enzyme ACE inhibitor for patients with diabetes or those who are under 55, but they are not Black, African, or Caribbean. So Caucasian population, ACE is best below the age of 55. And if patients are intolerant to ACE, and we'll talk about the intolerance when we are actually discussing ACE inhibitors, then angiotensin receptor blockade for patients who are intolerant to ACE but are under 55 years of age. For patients who are older than 55, calcium channel blocker are best, and especially also who have no diabetes and people who are of Black origin. Thiazide diuretic is preferred if calcium channel blocker is not tolerated or if there is evidence of congestive cardiac failure. If the patient is already on one diuretic, such as benroflumetazide, then don't change the diuretic to, say, indapamide. When patients have step 2, grade 2 version of hypertension, then you need to check on the optimum dose given and increase the dose if need be, and check compliance. And so using the ACD formula, there is an absence of B. So add on either on this side or on that side. If the patient is on A, which is ACE inhibitor, then add calcium channel blocker or diuretic, or one after the other. For Blacks, ARB is better than ACE inhibitor. Step 3, first review the optimum dose, because the given dose at an earlier step may not have been sufficient, and so the blood pressure has risen. So once the optimum dose has been checked, make sure that the patient is compliant and that the ambient blood pressure which they have provided you with has been correctly obtained. And at step 3, usually all 3 meds, ACE inhibitor, calcium channel blocker, and diuretic are also given. There is a 4th stage, which is that of resistant hypertension. And this is highlighted by postural hypotensive measurements. And to undertake that, you need to make the person stand for at least a minute and then take the blood pressure, and there should be 10 to 15 millimeter fall. A 4th drug may need to be added, such as spironolactone, and this requires potassium level monitoring and urea and electrolyte monitoring. At the same time, before spironolactone is used, commonly alpha adrenergic blockers are used if potassium is 4.5 or more. Even beta blocker can be used, and the alpha adrenergic blockers are like doxazosine. So we go on to now understanding these medications. Thiazide diuretics, they work on the basis of inhibiting distal connective tubular reabsorption of sodium and chloride. And because they work in harmony, the water and sodium loss occurs. And so when this extracellular fluid loss occurs and the volume is reduced as a result of diazide, then there is increased cardiac output. And this is in reflex. And with increased cardiac output, the peripheral resistance also changes. So the barometer for how much the artery is stretched and then the blood pressure rises accordingly, that barometer is reset after 2 or 3 days of using thiazides. So the mechanism is sodium and chloride and water loss, reduced extracellular fluid, increased cardiac output and peripheral resistance, resetting of barometer. That is baroreceptors. So the indication is, this is first line in elderly, 80 plus. It's contraindicated in gout, when there is acute renal failure, in pregnancy, and the side effects include erectile dysfunction, dyslipidemia, encouragement of diabetes. It does not cause diabetes, but it brings it out. Evidence-based medicine has been supporting that with the STOP2 trial, CAP trial, and MRC trial. Thiazide works on old and blacks. Beta blocker. The mechanism is it produces reduced cardiac output by reducing the sympathetic drive, by reducing the renin. And as a result of that, the baroreceptors are reset, leading to a fall of blood pressure, but also a reduction in the heart rate as well. So the indications of beta blocker are hypertension and ischemic heart disease, angina pectoris or myocardial infarction. And this is based on the studies published by Medical Research Council and United Kingdom Prospective Diabetes Study. Contraindication to beta blocker are relative contraindication to asthma. It is not contraindicated in COPD, although it is mentioned as a caution. It's contraindicated in heart failure and peripheral vascular disease. In fact, when beta blocker is given, it can exacerbate the peripheral vascular disease by redistribution of blood flow. The side effects are erectile dysfunction, and this was established in Medical Research Council trial and TOMS trial. There are also general features such as weakness, tiredness, apathy, anhedonia, and fatigability. The evidence-based medical records have come for beta blocker in STOP2 trial, captopril CAP trial, MRC trial, HAPPY trial, and UKPDS. So there's a strong evidence that it does work, although it is not the first line treatment now of hypertension. The other factors are that it is more effective in young Caucasians, especially if they have resting tachycardia. So please remember that the ABCD rule has changed to ACD, and in that, the beta blocker has been removed. So the first line medications are A, which is ACE inhibitor or ARB, C, calcium channel blockers, D, diuretics. But beta blocker has found its way in stage 4 and in people who have been on it for a long while in whom the clinicians do not wish to change. Calcium channel blocker. How does it work? It blocks the entry of calcium in the muscles. And these are muscles of blood vessels. So the dihydropyridine calcium channel blockers reduce the contractility of the muscles of the blood vessels, reduce the tone of the blood vessels, and by doing contractility and reduce tone, they produce vasodilatation. And vasodilatation allows more blood to flow slowly and therefore results in low blood pressure. But after a while, when the volume is distributed widely and the blood pressure has reduced, reflexly, the cardiac output increases and so does the heart rate. But eventually, this reflex response diminishes over time. And therefore, after a few days, blood pressure is reliably reduced in the patient. There are non-dihydropyridine calcium channel blockers as well. They work in the same way, but in addition, they decrease the contractility of the heart muscles, and they also slow down heart rate. So if you notice that the DHP variety slows down the cardiac output, increases the cardiac output and increases the heart rate. Here it just does the opposite. So non-dihydropyridine calcium channel blockers act like this, but they decrease myocardial contractility. So the heart is contracting less powerfully with reduced heart rate, and that leads to low cardiac output and low blood pressure. So both result in reduction of blood pressure. So when are they best used? Isolated systolic hypertension, hypertension with peripheral vascular disease, hypertension with cardiac manifestations such as angina pectoris, and this was established in CIST Euro-China trial. CCB, such as amlodipine, is contraindicated in heart failure and when there is aortic stenosis. Side effects of CCB are vasomotor, flushing, sweating, fainting, hypotension, those kinds of elements. The evidence base for use of CCB of either type for hypertension has come from NORDIL trial, diltiazem trial, INSIGHT trial, nifedipine GITS trial, and all of these reduce stroke. So CCB reduces stroke by controlling the blood pressure. So it has an additional benefit. Not only does it reduce blood pressure, but it also reduces the impact of stroke. And CCB is effective in young people as well in Blacks as well. Now, the first line is ACE inhibitor or ARB. I thought I would explain this better by explaining the other agents first. So how does it work? Angiotensin converting enzyme inhibitors block angiotensin 1 from becoming angiotensin 2. So when this blockade occurs, then it also converts certain bradykinins into polypeptides which make prostaglandin. So the unwanted effect of ACE inhibitor is bradykinin breakup, which makes prostaglandin, and the desired effect is not having angiotensin 2. And not having angiotensin 2, and of course, the polypeptides produce low blood pressure because of vasodilatation. So ACE inhibitor produces vasodilatation, and it achieves that by reducing the sympathetic drive and by reduced noradrenaline. So ACE inhibitor is a very potent and reliable um, hypo, uh, antihypertensive drugs. It particularly works best when there is heart failure. So it is indicated for hypertension plus heart failure, and it's very effective when the ejection fraction in heart failure is less than 25%. It's also useful in type 1 diabetics, peripheral vascular disease, and also in clinical situations where there is restrictive diseases as well. Contraindication of ACE inhibitors are pregnancy, renal artery stenosis, peripheral vascular disease, diabetes type 2, and NSAID. So obviously it is teratogenic, so it must be stopped. Anticipating pregnancy or in pregnancy as soon as it's diagnosed. Renal artery stenosis becomes worse once ACE inhibitor is given, and this is the reason worsening of renal functions as a result of worsening of renal artery stenosis is characterized by increasing creatinine and reducing eGFR. So this is the reason why urea and electrolyte test is done. NSAID are ibuprofen, Voltaren, naproxen, and so on. Side effects of ACE inhibitor are cough, and these are cough or cough variant asthma, tiredness, and nightmare. The evidence base comes from captopril trial, STOP2 trial, single publication of Yusuf et al. And ACE inhibitor reduces cardiac events. This is for sure. The CAP trial also shows that it helps the diabetics, although the UKPDS disputes it. There are other factors as well. Because blacks have low renin due to expanded volume, they do not respond well to ACE inhibitors. In this regard, in September 2021, NICE has promoted the use of sacubitril with valsartan, and these two have become now the gold standard of being antihypertensives, especially when there is heart failure with reduced ejection fraction. And this preparation is called Entresto, and we'll talk briefly about it much later. So if a person is intolerant to ACE inhibitor, then you give him sort of ARBs, angiotensin receptor blockers, or angiotensin receptor antagonist. And the way it works is it blocks all angiotensin 2. Though those which are escaped kinase are also blocked, and there are no circulating levels of bradykinin or prostaglandin. So that means if a person on ACE inhibitor has developed a cough as a complication, he will not develop cough with ARBs. The indications of ARB are cough, heart failure. It also offers renal protection in diabetes, and this was established by this research publication. Contraindications of ARB are similar to ACE inhibitors. Side effects are similar to ACE inhibitors, except for cough. And when there is cough following ACE, you give ARB. There are features of tiredness, nightmares, apathy, anhedonia. The evidence base is mainly from New England Journal of Medicine, but also from Life and Hope. And it does reduce cardiac events. And also it is very useful in patients with diabetes and left ventricular hypertrophy or left ventricular dysfunction. These studies have also shown that one should move away from beta blocker. So following these studies, beta blocker has been removed from the ABCD formula, and now the formula is ACD. Alpha blockers, they inhibit postsynaptic alpha adrenoreceptors relating to vascular endothelium. So this reduces or inhibits catecholamine, so adrenaline and noradrenaline, leading to vasodilatation. And that leads to control of hypertension. So a discovered action of the alpha blocker is to reduce the size of prostate. And so tamsulosin and finasteride are used as alternatives, but for hypertension, doxazosine is probably the best, and it also helps with dyslipidemia. The contraindications are postural hypertension, incontinence, and GI tract upsets. EBM, there are no good trials, and alpha blockers were withdrawn from all-HAT trial, but in ASCOT, they have a limited value. Nevertheless, being an alternative, fast-acting and strong, they have a place for use. So what does the evidence-based recommendations suggest? So LIFE has, the study has suggested that the losartan, which is ARB, reduces cardiovascular mortality, stroke, new diabetes, and left ventricular hypertrophy and left ventricular dysfunction. So ARB is recommended. HOPE shows the same. And LIFE and HOPE, both trials have recommended that we do not use beta blocker as first choice. New England Journal of Medicine has conducted several trials and published several trials, and it has clearly highlighted that ARBs are good for renal protection in diabetes. But there was an unusual trial called STOP2, which suggested that the old-fashioned medications produce nearly the same results as the new medications such as ACE inhibitors and ARBs in elderly population, but this is controversial. Since the end part of 2021, NICE has approved that instead of ACE inhibitor, sacubitril and valsartan, which have shown exceedingly good results as antihypertensive, particularly when the hypertension is associated with left ventricular dysfunction and with reduced ejection fraction. So this is now fast becoming the gold standard rather than ACE inhibitor. So the British Hypertension Society guidelines are, once you have diagnosed and treated hypertension, you need to continue to annually check the blood pressure, but if the patient is young and has not had blood pressure checked, then at least once in 5 years, blood pressure should be checked. If the blood pressure is consistently over 160 and the diastolic consistently over 100, treat it. And the treatment is also when the blood pressure is less than 160, but if there is target organ damage, such as edema, suggesting heart failure, renal disease, and when the Q risks are greater than 15% for 10-year coronary heart disease. ACE inhibitor is preferred for left ventricular hypertrophy and left ventricular failure. And now, of course, Entresto, which is sacubitril and valsartan. Beta blocker is good for ischemic heart disease. So if someone has been on this old-fashioned medication, you do not remove it. But there are now cardio-selective beta blockers, such as bisoprolol, carvedilol, metoprolol, which have reduced general side effects and act mainly on the heart. If the person has 10-year coronary heart disease risk greater than 15%, put them on aspirin. If the patient has 10-year coronary heart disease, which is more than 30%, put them on statin. And finally, you should continue to treat patients irrespective of their age, at least until they are 80, and then decide on merits and individualized treatment. So I hope that you have revised my presentation your existing knowledge of hypertension. Thank you very much. It's an important subject, and every few weeks there are some developments, and therefore it is important to catch up with these developments for better patient care. Thank you very much.